right. Next thing we're going to do is positioning and handling to foster motor function. This chapter focuses on peds, right? But a lot of their concepts you have to kind of follow with any patient. Doesn't matter the age of the patient, okay? Okay. All right, so function related to posture. All right, so supine, what is it? Supine and prone, sitting, quadruped, and standing. So supine and prone are the first kind of postures, right? To begin, and it's the easiest, in the easiest manner to move, right? When you're supine and prone, those are the first, let me see, your book describes it as being. Mm-hmm. Well, and you know, gravity's kind of helping you right there. Yeah.
You don't have to fight against the resistance of gravity.
So lower postural levels in which a child can function, right? Again, let's not just look at it as a child, just any body, okay? And then sitting is the second. So you have to be able to do things in supine and prone to be able to sit, okay? And for kids, primarily, right, you're looking for that head control, that trunk control. But adults too, when they have a CVA or any other neurological problem, sometimes they lose the head control. Right? So how do we implement this from a pediatric realm to an adult is that, what was one of the main things, let me ask, that there was a lot that this chapter talked about, right? But what for us as PTAs, we're implementing a treatment, what is the number one important thing to remember that you got out of it? Leah.
Out of the chapter, this is just sitting.
Chapter. What is the number one thing, after you read everything in the chapter, that you said, oh, this is the one thing I have to remember?
Kids are just, I don't know. I didn't get the whole chapter read.
Jojo? Okay. Rochelle?
I think what I thought about was make sure you're always supporting the head for like the infants and stuff.
Right, supporting the head, right? Okay, that's one thing. But if we're talking about both pediatric and adult, right? Alex?
To me, it was one point that I mentioned to remind that let them do as much as they can themselves.
Yeah,
And
so-
use it.
Good, right? So we've been saying that last semester, right? Let the patient do as much as you can. But in order for us to let them do as much as we can, what is one thing, Corinne, that you picked up from the chapter? No, just in general, like important things in this chapter. The one thing you took away, let's say.
I guess that choosing position is like you need to choose the right position in order to reach the functional goals.
Okay,
So
good.
that's like part of this.
Great. Yeah, very important. Yes. Jacob.
So, kind of the sense that I got from the chapters that there is a progression that you sort of have to follow depending on where they are developmentally. It's like going from supine to sitting. You can't just take them from supine to standing. You sort of follow this progression, and it depends on where the individual is developmentally.
Right. And you can, but then are they going to be successful, right? So you have to think about that. And then the other thing you have to think about is, at what point do I go from supine to prone, supine and prone to sitting, if I'm not really sure they're ready, right? So while you're not going to take them from supine to standing, right? You do have to challenge them on that way of that progression, right? But yes, you have to start with the easiest, which is activities in supine and prone, and then you have to progress. Same with an adult, right? If they can't sit at the edge of the bed unsupported with head control, with midline orientation, right? And they can't do static and dynamic activities, then standing will be harder, right? But, Ms. Beats, do you still stand your patients even though they don't have 100% sitting balance? And because what happens if you do? Right, then you're holding them up. Now, when I worked at rehab, we would stand them like that even if it took 4 of us, but it wasn't for function. It was just to stimulate them, just to get their body up, to stimulate the brain, all those connections, to say, oh, this is what it feels like to stand. But it wasn't for function and it wasn't therapeutic at that time, right? But you do need to challenge them, right? But yes, you have to start, at the bottom where they, where whatever they can do. So if your CVA patient cannot sit unsupported, then you work on that. You don't just leave them supine because you still have to stimulate that, right? Yes.
Is it still like considered like a base level of function to do that? Because like you're trying to teach them the motor. It's just not like a basic function.
No, because I mean, if you think, right, if you're thinking is, any neurological patient is laying there, they're laying there, can move their head probably not to one side, they're neglecting one side, right? But when you sit them up, they're not gonna sit for you perfectly. So that's your starting point. Because you can't leave them supine forever, right? But with the child, you start, there is a base where you start and then you progress, right? And then standing is the highest level that you're gonna get to, okay? So our intervention, daily routine, this is for children, right? Sitting is best if possible. Why? Natalie?
Sitting is best.
If possible. Why is sitting best for interventions, for us to do interventions?
Second,
Yes.
I would say that sitting if there's a possibility of function with their upper body.
Yeah, and what else? Not only just functional, what else, Cam?
Like it's better for like social interaction, but when video on the visuals, it's just
Right.
not looking at the ground, they're actually viewing what's happening.
Correct. And then appropriate level of assist, right? So we need to determine how much can the patient do, and how do we determine that? But what Alex said, letting them do as much as they can. And then from there, determining what level can I progress them at, right? So you're thinking back at your TheraX class and you're like, okay, we're learning at what level should we start for certain things, right? Because you all want to go up to the high dive board where you need to stay in the kiddie pool. So again, where are you going to be with these kids, right? Again, you're not all doing pediatric therapy. As an adult, for adults, what level am I going to start at, right? Or like we said, if they're not sitting, why would I stand? Right? All right, home program, very important for children. Stretching, and then giving them handouts, right? Stretching, because a lot of the diagnoses that we're going to talk about, they don't have normal muscle tone. They're either spastic, or they have synergies, or they have contractures. So stretching is super important. And again, unlike an adult, you can't sit your kid there and just stretch the heck out of their hamstrings, right? You have to positioning, so it's passive stretching while they're playing, while they're doing all sorts of activities, while they're sleeping, okay? And of course, you're not going home with them, so you need to provide the patient's parents, the children's parents, with patient education, handouts, to ensure that they're going to follow that program. Positioning and handling interventions, positioning for function. So anything you want to do, it has to be functional, right? Our goal is always function. So for children, what would be, let's say if you have somebody sitting up, you're working on sitting, what functional item are you helping with? Who haven't I picked on? Evie. So if you have them sitting, what functional item are you working on while, because they're sitting? What function is easier for a child? What can they do easier if they sit?
Drinking?
Mhm.
Eating?
Eating and drinking,
Yes.
okay, very good. The other thing in your book really describes all these different ways and good ways and bad ways of holding kids, right? And some of them encouraging that stretching, that positioning while you're holding them. And carrying positions as well. And then handling techniques for movement, right? Where do you facilitate them? Where do you put your manual contacts for the child to just, kind of get that stimulus and then move, right? You don't want to do it all for them. Again, with an adult, you're going to do the same thing, right? If I want their head to come up, maybe I'll just tap their chin, right? Or bring it up like that, or their back, for them to sit upright or stand upright. So again, a lot of your handling, not manhandling, okay? Don't manhandle people. It happens. And I don't want to say, I'm not being, like somebody accused me of being sexist the other day. You boys have big hands, right? Be real careful and gentle. Have you ever had somebody with a big hand try to caress your face? Right? So be careful, because you already are coming in and looking really big, right? And tall and strong, and the little old lady's like, oh, they're gonna hurt me. And I think they'll love you, right? It's the opposite. Oh, honey, carry me. So you have to make sure they work, okay? All right. Allow the child to move as much as possible. Again, encourage head control. How are we going to do that? There's different activities to do that. Do not pull against spasticity. What happens if you pull against spasticity? They're just going to get more spastic, okay? Weight bearing for children with athetosis. Did somebody look that up?
I did. It's conditioned with abnormal muscle contractions. It causes involuntary riding movements.
So they're just kind of not able to control that. So again, weight bearing diminishes that. Weight bearing is really big with everybody with a neurological condition. Children and then everybody. Weight bearing is the key. They can say, what are you going to do with your patient? Weight bearing activities is always a good answer, but then you have to be specific. Place low tone children in prone. What does it mean by low tone? Okay, what would a low tone baby look like, Ben?
Well, I read in the book that like you can't hold them to
Right, so what
They don't have any clothes.
is there a couple words you could describe as that? Huh? Well, yeah, a low tone baby. A low tone baby is floppy.
Yeah, like floppy.
Oh my god, I was thinking that. I thought I was looking for.
Huh? How about a rag doll? What does a rag doll do? It just kind of right? So that is low tone. Okay?
With low tone, do they look like skinnier too?
Yeah, I mean, they just look, you can, I mean, I don't know if you guys look at some of those videos for the, development that I put in your thing. When it does the developmental evaluation, you have a normal baby and you have one that's not developing, and they pick him up and he's just like, you know.
Yeah, the abnormal baby looks like smaller and
Yeah.
like weaker.
Yeah, because I mean, your muscles aren't working, you know, normal babies tend to move, they're pretty strong, right? And when you have either, you know, increased tone, they just look really stiff, low tone, they just are like rag dolls, floppy, okay? Again, we talked about where are you putting your hand? So wherever you have your hand on the child or on an adult, that's what you're not letting them move, right? So your book mentions how the shoulders and the hips are where you're going to control. If you're controlling them at the hips, that means everything above they are able to control. If you're holding them at the shoulders, right, you're kind of controlling the head or not controlling the head or the hips. So if you're, you know, giving them too much assistance, you're not letting them move. So in an adult, the same way, you have to allow for them to move, right? You have to allow them, and we're gonna go through this where you're like, yes, I need you to be real close, but I also need you to back away at the same time and let them do what they can, okay? Again, decrease handling as the child gains control. You need to figure out at what point am I going to back away and let them, you have to let them struggle a little bit, right? You have to let them work. Even normal babies hate prone. They hate it, right? Because it's not comfortable. You have to make them do it. Sensory input, touch, right? Vestibular system, your book goes through the whole thing about, you know, going in through that line, if you put them on a swing, all that, you know, pediatrics uses swings a lot, right, for that vestibular facilitation and so forth. The one thing that I remember from that vestibular thing is you can't always do the same facilitation. They adapt. And then you don't get that reaction you want, right? And your book talks about how they do babies who are low tone, not very active, not very awake, and you put them on a swing and they just kind of like wake up, but after a while they get used to it and it doesn't work. So then you need to move on. We're gonna talk about approximation, but vision, okay, visual, right? That's why we want them sitting, so they can see. As soon as they're, you know, their vision is completely normal, you know, because at some point they don't see everything, right? And at some point they're able to see farther and clearer, and then their hearing. So their vision and their hearing, if they can't see or they can't hear you, then it's gonna make it a little bit harder, right? You have to figure out how to do these things. Only with a child? No, with an adult. If they can't see you, or they can't hear you, or both, you have to figure out a way how to communicate with them, right? Or if they can't understand what you're trying to tell them, or they can understand what you're telling them, but they can't express. So again, during treatment, when you're having to give tactile cues on a timely manner, verbal cues on a timely manner, you expect your patient to respond in a timely manner, and it doesn't happen, right? So then that's your job to figure out how to do it better. What works for the patient, one patient may not work for another, okay? Approximation, what is approximation? Leonda?
I don't know.
This is another word like weight bearing or weight shifting, another very important word for you guys to know because we're going to use it a lot. It's in your book, I highlighted
Isn't
it.
it the feeling of the joints compressing?
Yeah, approximation is you're compressing straight down, which stimulates your muscle, right? or your sense in space as well. It's in your book, I highlighted it.
It's page,
115. What is it?
Application of compression for joint weight bearing.
So if I finally got somebody sitting, go ahead and sit straight up for me, Miss Leonda. She's on the ball. If I have finally got somebody where I want them, then I'm going to approximate straight down. I can do it here at the hip too, right? So that tells them, okay, this is where I'm at, this is where I really want you to, this is straight. This is where I want you to be, this is straight. So you kind of get that, sense.
And that can help someone with neuromuscular disorders.
Oh, how much we use approximation? It's like, remember, what's your treatment plan? Weight shifting, weight bearing, approximation. It's like, we're doing that continuously. Those are two things that you do.
All constant.
Yeah, I mean, that's just it, right? Because you're giving them that sense. So grab a partner, one of you sit upright, and the other one approximate at the shoulders and then at the hips. It feels different when you're not in a ball. I know it probably.
Okay.
Yeah. What do you feel like?
How do you feel? It's like solid.
Solid, right? And then do it at the hip.
I feel nice traction there though.
Okay?
How'd that feel?
yeah.
It's just like more stiff, like.
Not a bad way weird, but like I can feel it go all the way. I can feel it going all the way down. Well, that's what I'm saying here, but especially like midway through thoracic.
Why are you pushing me down? It's like,
Like you can like feel it going all the way
it almost feels like when you do the
Yeah, I could feel it kind of.
But the middle stage, how do you just do it less and let them feel through it, is that too much later? Oh.
Now, that's grand. And, well, let you do it. Come over here, Miss Beats. What else can we approximate?
Joints?
Yes? Yeah.
Probably do like the wrists.
That makes sense.
You can pick one of them.
Who wants to do my picture?
Just pick one.
I don't know anybody's name. Pick a color.
You in the green.
Yeah. So the way I've seen it done is you want to sit down, and you're a stroke patient, so you don't have, you have a flaccid left side. I would get you to bring your arm out here, and you're flaccid, so she's going to be falling to the side, and this arm's really not going to be supporting her. So I'm going to be making her try to put weight into that flaccid joint. That's how I would do approximation.
You just have to protect all joints because they're just gonna collapse on you.
And
Okay.
usually it's like a two-person kind of thing, because this person probably can't even sit up, so you're like having one person hold their body while you're working on this joint right here. I've just done it on the affected side, I guess I mean, this side is gonna be perfectly fine.
I was gonna say, why would we do it on the normal side? It's the only one they're using. So, I mean, why do we use approximation? Right? If they're using this one, normally, they're getting normal feedback, right? Oh, come back. Or no. Now, sometimes when they're sitting, I'm too short. Get down. Again, think about, and we're gonna do a lot of actual hands-on for these stroke patients, because you're not gonna learn in the book. You have to learn how to handle them, you know. So, and this is part, right? This is pediatrics, but this is all part of what we have to do when we handle patients. If this side is flaccid, it means it's the whole side, everything, right? So, maybe I lost some proprioception in my foot. I don't have that feeling, right? You still have sensation. It's hard to say how much, you know. I had a student say, well, they had a stroke, they don't feel anything on that side. Yeah, they do. They still have sensation. It's a sharp, dull, it can be hypersensitive. They can have low sensitivity. You don't know, but you still have to, if they're hypersensitive, you really have to be careful, right? Always tell them you're gonna touch them. For somebody who's hypersensitive, what kind of touch is best?
Slow and like.
Soft kitty. That's gonna irritate the heck.
Like slow and firm.
Have you ever, has your limb ever fallen asleep and you touched it? What happens? It's worse, right? So for hypersensitivity, pressure is the best, right? So you can also approximate the knee and your ankle. You can do it down here for the foot, right? If they stand, you can do it all the way from here. Right, sorry. Right? So, again, approximation you're going to use all the time. Thank you. You can go now.
Is it starting like approximately a little bit better? I feel like the husky something
For approximation,
No, for like if they're hypersensitive, isn't there like is it like proximal is better to start with, or is it better?
I don't know. I don't know.
But the big
Pressure, yeah, pressure. Posture readiness, right? How ready are they, like we talked, how ready are they to move? Can they sit? Are they able to sit unsupported and so forth? So you have to determine where they're at, posture-wise in terms of when are they ready. Postural alignment is very important, right? Before, you could have the head up, you could be holding their head up, but if they don't have posture alignment, things aren't gonna work, right? So you have to have head control, trunk control, they have to have good posture. You're gonna use manual contacts, and they talk about rotation because rotation is used to calm things, right? When we talk about PNF and those things that I think we're gonna do on Wednesday, rotation, there's a lot of different techniques in PNF besides the diagonals that we use to facilitate or inhibit. Rotation is an inhibitory motion for increased tone, elasticity, right? So if their arm is really tight, right, just hold it tight. I'm gonna come in here and just rotate, right? Open. When somebody's like this, you open that, you have to pull the thumb out, the rest will come really easily. The moment you touch their palm, they're gonna close. So you have to kind of keep them here, right? And you're going to rotate. Rotation relaxes, okay? Manual contacts, again, how much are we holding them? Where do our hands need to be, right? You'll learn you have to move your hands. If you're working with somebody who's pushing back and you put your hand in the back, what's gonna happen? They're gonna push against your hand. So again, knowing when to not touch them in that manner, okay? So here, position to encourage head control, prone oval or bolster, or supine on a wedge. These are for kids, of course, you know. I mean, I guess you can put an adult over a bolster, but how big is the adult? In one of the, few years ago, I gave a case study of a spinal cord, no, is it a head trauma, TBI, stage like 1 or 2, and I said, come up with a couple of activities, and one was to put them prone on a bolster, and I'm like, how big is this patient? You know, if they're 200 pounds, are you gonna put them on a bolster? And why would you put them on a bolster when they're not awake, right? Again, let's think through these things, right? But this is talking about kids. How would you encourage head control for an adult? Okay. Remember, they're not gonna just go in that same progression as a kid, right? You just sit them, make them pull up, right? Anything else? Do you do anything in supine or sitting? Or prone? Supine or sideline? I just would sit them. Just get it done, right? Yeah. Again, a modified pull to sit maneuver, upright and supported sitting, weight shifting from supported sitting, carrying and prone, because they have to lift up, right? Carrying upright, prone in a hammock. This is for kids, because you can handle them here. For an adult, we have to think about different ways, okay? Things that are trunk control, fosters trunk control or independent sitting, sitting propped forward on both arms, sitting propped forward on one arm, and it's a progression, right? And again, in an adult, we have to modify this. What encourages trunk rotation or trunk control, coming to sit from supine, coming to sit from prone, coming to sit from sideline, sitting to prone, prone to 4-point, 4-point to side sitting. Okay, so this is just more advanced. And then kneeling, which, right, is even more, your equilibrium has to really be kicking in here. This chapter really gives you a nice outline of what to do for each thing, right? What activities, what fosters each prone, sitting, standing. Sitting posture, side sitting requires rotation, right? So if they're stiff, you have to work on that before you expect them to get into that position. Adaptive sitting. What is adaptive sitting or adaptive equipment? Right. Any equipment they're gonna use to support them, right? The standing frames, bolsters, balls, etc. Avoid wide sitting. Does anybody know why?
They didn't say the point why, because they're in a wide city, the base of support's bigger, so they can't work on their posture and stuff.
Yeah. Yeah, there's issues with your hips too, right? When you do use this adaptive equipment, you have to, psychological benefits of what? Somebody mentioned it earlier. What would be one psychological benefit? Somebody who cannot stand on their own to be able to stand.
Confidence.
Confidence. What else are we doing when we're standing up? Social engagement. What's happening in the body?
They're teaching the body how it feels.
Okay. What did we just talk about in terms of things we always are gonna do? Number one. Weight bearing. Weight bearing. You're weight bearing, right? In a normal position that they can't achieve by themselves.
And the psychological benefit of the weight bearing? Or
Well, the psychological benefit of just standing is that they're able to interact at the level that everybody is able to interact, right?
yeah.
Their function should be better. They should be able to bring their arms up to feed, right? They can comb their hair.
Can it also be like wavering or standing things like
Yeah, it can be. And then rollators are like walkers, but it's within a standing frame. They can walk with it. What else was I gonna mention? I think that's it. All right, so let's come back at about 10-ish. We're gonna break, well, you're each gonna do your first case study. You're gonna each get a different case study. I'm gonna give you 30 minutes to work on it, then we're gonna talk about it, and then you turn it in. No, you're by yourself. You by yourself. So if you didn't read the book, guess what? It's gonna take you longer.